Okay, everybody. Welcome to the American Initiative in Mast Cell Diseases webinar series. My name is Stephanie Lee. I am an assistant professor of medicine at the University of Toronto and the director of the American Initiative in Mast Cell Diseases Education Working Group. And I'm hosting this today with Dr. Jason Gottlieb, who's a professor of medicine at Stanford University and the president of the American Initiative in Mast Cell Diseases. Today, we are hosting a webinar on the role of allogeneic stem cell transplantation in advanced mastocytosis. And our objective today is to provide a pragmatic approach to the role and timing of transplant in advanced mastocytosis in this current TKI era. And to achieve this objective, we have a panel of three esteemed experts. I'm joined today by Dr. Radia, who's a hematology consultant at Guy's and St. Thomas's Hospitals in London, UK. Dr. Sela Ustin, a professor of medicine, the Coleman Foundation Chair of Hematology and BMT, and the Director of Cell Therapy Section at Rush University Medical Center in Chicago. And Dr. Andreas Reiter, a professor and consultant of hematology and oncology at University Hospital Mannheim in Germany. Because we want to provide a pragmatic approach, we really want to bring this back to the patients. And so we're presenting three real patient cases today to illustrate how transplant fits into the current treatment paradigm. So we'll get started with our first case, which is a patient with aggressive systemic mastocytosis. It's a 57-year-old man with a 1-year history of progressive fatigue, abdominal cramping, and weight loss. The exam was relevant for a spleen that was 5 centimeters below the costal margin, and there was no palpable hepatomegaly or any other clinical abnormalities. A laboratory investigation showed an anemia of 9 grams per deciliter, mild thrombocytopenia, a normal white count and differential, a tryptase of 60 micrograms per liter, normal liver function test, and an albumin of 30. The bone marrow showed an aspirate with no increased mast cells. Trephine showed multiple mast cell aggregates comprising 30 to 40% of the cellularity, and there was no evidence of an associated hematologic neoplasm. Molecular analysis showed a KIT D816V mutation with no additional mutations on NGS, and there was a normal male karyotype. So our first question to our expert panel, and I'll ask Dr. Radia this, what is your treatment approach to pure aggressive systemic mastocytosis? And by that, for some audience members who may not know what we mean by pure, we mean aggressive mastocytosis with no associated hematologic neoplasm.
Brilliant. Thanks very much, Stephanie. Pure ASM, I mean, we've just got the c-KIT mutation. We don't have any other from the NGS panel. There's no suggestion that there's an AHN at all. These patients do extremely well with the new potent TKIs. So in terms of a transplantation question, it wouldn't be the first thing that would enter my management criteria. If I saw this particular gentleman, they do extremely well. We know that from the Pathfinder trial, that the pure ASM patients usually reach a CR and really deep remissions based on the TKIs that they're given, both in the trial with the bezuclastinib and the avapritinib. So for me, it would be treating with a more potent TKI, taking into account that making sure that their cardiac status, we haven't got the background history here, their cardiac status is fine, they haven't got any contraindications to start a TKI, and I noticed that the platelet count was fine. I would be looking at starting this particular patient on the most available TKI or trial.
Wonderful, thank you. And for Dr. Ustin, would you offer this patient a transplant in the frontline setting?
Sally, you're on mute.
Sorry about that. It's a common mistake. We still do it. I still do it. Yeah, no, thank you. I would not offer allogeneic stem cell transplantation. I completely agree with Deepti. Because we know that with the efficient, very efficient KIT inhibitors, their progression-free survival and overall survival in aggressive systemic mastocytosis is very good. It's not like in the prior era, these patients were having perhaps median survival somewhere around 2, 3 years. It has changed, and the group that the investigator is, and most of us are included, also show that with particularly avapritinib, for example, 3 years survival and effect of avapritinib is very good. Only less than 10% of patients showed progression. So, and we also know that from allogeneic transplantation studies, like the patients with ASM still have tendency to progress. So the short answer is no KIT inhibitor upfront, no allogeneic transplantation.
I just ask a question here to the panel, and that is not every country, of course, has access to avapritinib as first-line option for advanced mast cell disease. Would your mind change if the availability of midostaurin versus avapritinib? Would you still go with midostaurin versus transplant?
I'm happy to kick off, and then I think Andreas and Chela, we were in that situation. We were 2 years behind getting avapritinib licensed. We just had that done recently. So when patients did come to us, we had an option. And actually at that point, transplant was higher up in my repertoire, because if they were young and you're looking for the only curative option, it was something to think about. I would always try midostaurin, and a lot of patients got midostaurin because we knew that you can get some partial and some good, moderate, major responses, because you really want to decrease that SM burden to as low a value as possible before approaching transplant, and also trial. So for me, those were higher up than transplant. But we ran transplant in parallel to see if they had a good match, to look for donors, just to see if there was anything that would make a transplant move higher up in that management priority for me. Andreas, what did you do when you were waiting?
I think that, to the best of my knowledge, the UK is the only country in Europe in which avapritinib is now approved for first-line treatment. So in all our other countries, we still, let me say, only have midostaurin. But I have to say, midostaurin is also doing quite a good job in a proportion of patients, so it's not generally bad. And if you really, if you stay with your patient, you adequately treat nausea, which improves over time. We now have also data that you may not need this full dose of 200 milligram daily, so also 100 milligram may also be enough. So you need to find a compromise between efficacy and also tolerability. And then now I would like to also to say something for both drugs, for midostaurin and avapritinib. So I think that I would also look at the dynamics of response. I mean, we know that there are baseline parameters, and of course, I'm always looking out whether there's AHN, and I think AHN, the definition, I mean, there's something to do, because I mean, AHN may be there morphologically, very clear, visible with monocytosis or eosinophilia, but it may also only be there via genetics, so not morphologically visible, but one or two additional somatic mutations. And maybe we also need to find some new definitions on that. And saying that, I also think that the baseline allele burden is important. I mean, you will see also with the next cases, I'm a great friend of doing the allele burden or variant allele frequency always in the bone marrow and also in the peripheral blood. I also like to know the allele burden of additional somatic mutations. So overall, I mean, advanced systemic mastocytosis has always been very complex, but now it has become even more complex with all the knowledge we get from the genetics. And I think, of course, now we say about this case, it's pure ASM, and I would definitely be 100% with what Dipti said and also what Chilla said about treatment and not going for transplant. But I think kinetics of response is also very important. And I would also like to give back, maybe the answer also to Dipti and Chilla. What would you do if now this patient would really achieve a very, very good response? Let me say after 6 months, we see that. We see complete remission, bone marrow mass cell infiltration, TRIP test, kit TH16V, and the patient has an excellent donor, and the patient itself is in excellent condition. I mean, transplant would really mean to cure the patient. And so let me say that, or let me ask Jela and Dipti, and also Jason, of course, and Steph also. Sorry.
Tyler, what would you do?
Yeah, I think so. A couple of things. First, Andreas, your group showed that you are right. The VAF response to midostaurin within 6 months, I believe, if less than, I think, if I am not correct, 25% or 50%, that patients have tendency to progress. So you are right that perhaps if we start with midostaurin and following midostaurin response can be key to decide in some countries allogeneic transplantation should be offered or not. That might be a very objective uh, uh, factor to make decision allogeneic transplant. So I had started. I am a bone marrow transplanter, so I have a bias, and when I had started in mastocytosis, my thinking was always allogeneic stem cell transplantation. But if over time, I have learned and things have changed, and if when this question comes, if patient responds to avapritinib or midostaurin very well, shall I do allogeneic transplantation for to cure the patient? And today I will say no. Because if they are responding, the loss of response is rare. And again, please panel to correct me if I am wrong. That's my perception. So I will not take a patient who is particularly responding very well and do transplantation to cure the disease. I will just keep continuing the uh, KIT inhibitors. And if the patient starts progressing, then allogeneic transplantation should be offered at that time because there is no other therapy option. I'm still skeptical that allogeneic transplantation, or we know how to use allogeneic transplantation in ASM and MCL in optimal conditions. There are progressions happening somewhere around 40 to 50% of patients after allogeneic stem cell transplantation in these patients subsets.
And I think
So I think, sorry, Steph, after you.
Sorry, I was going to say, thank you all for your very thoughtful replies to these questions. And it does bring up the point, I think, that I want to highlight here is if this was pure mast cell leukemia instead of pure aggressive mastocytosis, would that change your decision making? Meaning, if there's still the absence of an associated hematologic malignancy, would you still have the same treatment approach? So maybe I'll address this to Dr. Reiter.
When I saw your cases, I was really very happy that you used this term of pure mast cell leukemia, because this is also something new. I mean, we have just learned that when we did the work on CML, and particularly when Jason put together the data within the European Competence Network on mastocytosis. So this is really a new, two new entities that we have to separate mast cell leukemia between pure mast cell leukemia and mast cell leukemia with associated hematologic neoplasm. Whatever we define that, I mean, of course, mutations are very important, but and also the morphologic picture, as I said before. And now what we see from Pathfinder, from the 3-year follow-up, which we presented at last year's EHA meeting and also at GASH meeting, we see that particularly these two subtypes now, what we now call pure ASM and pure mast cell leukemia, they really do exceptionally well on avapritinib with a really excellent long-term survival. And my question to the audience, I mean, it was really let me say provocative. So because I do not know the answer either. But I mean, we also know from our work what we did. We looked now again just 2 years ago into 70 allogeneic transplants which have been performed over a period of about 20 years in Germany. And we saw that transplant is extremely good in patients with response on whatever, but that, let me say, the chemo-resistant and probably also the KIT inhibitor-resistant mastocytosis, these patients are not really good candidates for transplant. So maybe really it's the same situation like we see also in AML, that really the good responders are also good. The good responders on the KIT inhibitors are also good candidates for allogeneic stem cell transplantation. And maybe now with the availability of 2, 3, or even 4 KIT inhibitors in the foreseeable future, it may be an option, like we do it nowadays in CML, to wait the response and the progression of the first inhibitor. But if we then use the second inhibitor and the patient has then a response, that we should then definitely go for the transplant.
Right.
You know what I mean?
So just to mention when we did the good practice guidelines, we looked at all of this, and when you come to the pure ASM and the pure MCL, not only do they have really good deep responses, and we're looking at path responses and clinical responses, but also the longer exposure there is to the more potent TKI or even midostaurin, the response gets deeper over time. And a lot of these patients end up with lower doses to keep them where they are. So they are in a good place. The only thing I would mention is that we did separate those who had chronic and acute MCL, if that still exists, because it depended on the tempo of the disease. Those that have been chronic for a long time are really akin to the ASMs, but those that have a high disease bulk may have a different tempo, and maybe they might need to be considered earlier for a transplant, and that would depend on that patient.
Right. And to complicate it even further, or maybe not complicate it, what do you think if someone had pure ASM or pure mast cell leukemia, but was KIT wild type, where you can't reach for these very potent and efficacious KIT inhibitors? Does that change the way you incorporate transplant into their treatment?
Again, within our registry, we found something like, I do not remember exactly, 10, 20 patients with this really wild-type KIT, KIT. So we really sequenced the whole KIT region, and we did not find any mutation. And what we found is, to our surprise, that these patients do not really have frequently additional somatic mutations, but still prognosis is very poor. And when we use the MAS score, for example, which includes also additional somatic mutations, you cannot use the MAS score. And then on the other side, we also know that we have very poor response of these patients also on the regular KIT inhibitors like midostaurin. And I think I haven't seen this data yet from avapritinib, but I would guess that because avapritinib is a very specific KIT D816V inhibitor, that we may not see really, let me say, the same sort of deep and durable responses on avapritinib. And all my experience I have that this is really, I mean, KIT wild type mast cell leukemia is really the worst, the worst, the worst subtypes with, I would definitely guess, median survival definitely less than a year. And I have seen, let me say a handful of patients in which not even AML-like intensive chemotherapy or, the conditioning of allogeneic stem cell transplantation did anything to the mast cells. You just do the first bone marrow of the intensive chemotherapy 3 weeks later after transplant, and the mast cells have been in several patients at the same quantity in the marrow, just as prior to chemotherapy or to transplant. So this is, and the only thing I would like to add is, if it is really this well-differentiated systemic mastocytosis, if your pathologist can, and we have the data there from Spain. I haven't seen, I have to say, a lot of these cases by myself, although we have seen a huge number of patients with mastocytosis. I mean, this is probably the only cohort of patients in which I would still try imatinib based on the data from
Right.
Spain. But we have used imatinib also maybe in a handful of patients, and I've never seen any, let me say, really significant and nonetheless durable response on imatinib. But maybe Chase, I do not know whether Jason can also say something about his experience. I have no good experience for imatinib in.
I was just going to ask that, I think, Steph, you've had at least one, if not two cases that are wild type KIT on, I think on Pathfinder, taken off and put on cladribine, and I think you've had some very nice responses. Is that a fair characterization?
Yes, I had 3 patients with KIT wild type mast cell leukemia. One patient passed away within a few months. She had a very particular aggressive disease. And the other 2 patients responded absolutely beautifully to a single cycle of cladribine and went on to get transplant. The first patient then relapsed from transplant, got cladribine again, went into a CR, is getting a second transplant actually. And the other patient is only, 90 days post-transplant, but doing wonderfully. So in my experience with KIT wild type mast cell leukemia, cladribine has been incredibly effective. Not a lot of patients, but that's been my experience.
So
No,
would you?
I can confirm that, but that they respond, but they usually, as your first patient you mentioned, they may really experience, at least in our experience, rapid relapse.
Right. Yeah. Yeah. You
So
can't,
they're going
they respond, but you
to.
can't keep them there very long.
Yeah. They don't maintain any sort of remission. I was just going to throw out there with the cladribine, it's just debulking and keeping them down. So it's just holding,
Yeah.
unless you've got a transplant that's curative. But has anybody considered trying imatinib with cladribine? Would that be they just don't respond to imatinib at all? Because I know we're talking about the well-differentiated SM and they follow a slightly different tempo. But has that ever been considered? Or is that just a place not to go? Because I know folks will look at somebody being c-KIT negative and based on the education that we do with the well differentiated might think about imatinib. I don't know of any cases that have had imatinib used
Yeah,
or
I've
been
only
successful with it.
tended to think about using it if they have a, juxtamembrane KIT mutation, because I really don't think it has a
Yeah.
substantive role in patients who are KIT wild type, but without a juxtamembrane KIT mutation.
So really these need to be treated a bit like the MCL-AHNs or the AML, in the fact that you want to debulk them and try and get them to transplant as quickly as potentially possible, depending on what's going on from a transplant perspective. And the likelihood of relapse of these patients is high.
Yeah.
So again, debulking them, holding them is really a place at the minute.
Yeah,
Would that be a reasonable?
Yeah,
I
I think
think
reasonable. I'm not sure people have the luxury of time to wait on imatinib, and somebody has very dynamically active disease trying to get them to transplant.
I think for the wild type KIT, it's also something important, what Dipti just said, that you find out, is it more acute or chronic? Although I do not really that much like these 2 things, but the well-differentiated mastocytosis presenting like a mast cell leukemia may really be more a chronic one, and you may have more time for decisions. And we still use cladribine. So another a word that Dipti said is the debulking of the disease when we really have a patient, let me say, with 90% mast cell infiltration, tryptase of 1,000, and then 50% allele burden. And when we sometimes believe that such an oral drug is just not doing the job quickly enough, probably. I mean, that has changed a little bit with avapritinib. So avapritinib may be quick enough, but we cannot use it, not yet, first line. So we have still to see. And then we have sometimes used, indeed, cladribine with midostaurin. Cladribine debulking 1, 2, 3 cycles, and then to use midostaurin. But we haven't really seen responses on midostaurin in wild-type mastocytosis, wild-type KIT mastocytosis.
Okay, thank you everybody for these great responses. I will move on to the next case. So this is a patient with SM-CMML, 67, long-standing low-risk CMML, and then presents with weight loss, fatigue, and progressive cytopenias. Has hepatosplenomegaly on clinical exam, otherwise no ascites or anything else notable on exam. Has a mild anemia and mild thrombocytopenia with a white count of 11 and elevated monocytes, no circulating blasts, a tryptase of 98 micrograms per liter, an elevated ALP, and essentially normal albumin. The bone marrow shows dense mast cell aggregates with CD25 and 30 co-expression in spindle-shaped cells, multilineage dysplasia, myelomonocytic proliferation with normal blast count, and all of this consistent with histopathologic diagnosis of SM-CMML. Molecular status shows a KIT D816V mutation, an SRSF2 mutation, and then 2 pathogenic TET2 mutations, all at very high VAF. Normal male karyotype, and risk score shows a low risk for CMML by CPSS mole and high risk by the various SM prognostic scoring systems. And so my question for our expert panel, I'll start with, what is your general approach to SM-CMML, Dr. Radia?
So really beautiful summary of what you see. You've got a CMML naught, you've got to look at both those conditions. And if you go back to your slide, you can see that the VAFs, their variant allele frequencies, are fairly high across the board. And I think this brings into mind that you are trying to separate these two and looking at them individually. They're both in the bone marrow trying to prognosticate, and the CMML score is low. The patient does have splenomegaly, they're anemic, their platelet counts would allow it. That VAF is high for a KIT VAF within the SM bubble of KIT.
Right.
So I would be looking at treating the SM component here in the first instance. But the challenge is watching, because there's a seesaw act between, we've already mentioned, I think, Chella, you mentioned, didn't you, there's progression, either within the transplant or within the trials, we've seen up to 20% progression, and it usually happens in the AHN component. So for me, with this particular case, I think I will be aiming for the SM treatment first, watching the NGS, and looking at the bone marrow to see how things change. You'd expect to see a response with a potent TKI for the SM within 2 to 3 months to see what changes are happening. That's how I would start, but watching very carefully to see if you need to change to treat the other component. And the curative option for this young person would be a transplant. It's how to get them there.
Right, exactly. And so at this moment in time, Chella, would you offer this patient a transplant at this moment in his disease course?
Well, I echo what Dipti say. Absolutely. I look at the scores for SM and AHN, and if any of them requires, and again, for particularly AHN, because AHN is still interestingly, with the new KIT inhibitors, became the worst group. Still, the progression is happening in AHN. The KIT inhibitors seems to be not adequate so far. So, and interestingly, again, the 3 large studies in allogeneic transplantation, the German group, and we did all together, and we are trying to do with the CIVMTR smaller size. Um, the best overall survival and progression-free survival is in the SMAHN. So that's very interesting. So ASM, MCL, poor responses to transplantation, but very good responses to KIT inhibitors.
Okay.
But SMAHN is opposite, very good responses to transplantation and poor responses. Perhaps still some improvement for the KIT inhibitors alone. How to treat this patient is a $1 million question. And I agree with Dipti, and I did. And when I saw the case, and I said, "This is my patient. The same TET2 mutation, SPF2 mutations, and I had this patient. She was asymptomatic, but was diagnosed in 2020, 21 with monocytosis, followed and then figured out that she also had SM, referred to me. I said, okay, low risk, um, and she didn't have high risk SM, mostly indolent. I should treat this with KIT inhibitor and see what happens. And I treated with KIT inhibitor because she's asymptomatic. She has no symptom whatsoever. Uh, Beautiful response. Beautiful. Her tryptase went down, monocytosis went down, platelets went up. It's like, wow, small drug, small dose, one drug, go home and feel good, I guess. But we also follow, obviously, very, very closely. And our peritoneum caused neutropenia. It was significant despite all reductions. I tried 25 milligram every other day, every 48, 72 hours. Whatever I did, I could not handle the neutropenia. So then we said, okay, your response is great, but you cannot tolerate it. Then we switch to NHMA. We work with the local doctor, oncologist. Very close monitoring, very close monitoring. She did well with the decitabine, and she was excellent patient. She followed very, very closely. We did bone marrow biopsy. Bone marrow biopsy showed no progression. We were happy, but in literally 3 weeks from um, from completely stable disease than AML. No warning sign, nothing. It just from CMML, she developed very abnormal blood counts, became symptomatic, and guess what? It's packed of AML cells, myeloid blast in the bone marrow. And it took 45 days inpatient service to treat this patient with induction, a lot of sepsis. She was almost dying. So, and she recovered. She was in good response. She had sibling. We immediately moved to transplantation this time. We didn't wait. And she has been now 8 months post-transplantation, has no symptoms and complete remission in both SM and AHN. And so now, we learn from patients. Yes, these patients do not require transplantation. That's what I did. But it's scary that we literally, with no warning, from CMML to AML, and she was dying. Literally, she was dying. The disease was gonna kill her, and therefore it was very hard to give her induction. Induction was gonna kill her. and transplantation is working very well. So now, if I see someone like this, ISM or or like your case, high risk SM, but CMML is at the lower risk. Can I offer transplantation? I really seriously consider doing transplantation in them. I will have that discussion with the patient, and because to me it's really unexpected, but it happened.
Thank you. Thank you for sharing that. Yeah, I think anyone who ever treats CMML probably has similar cases of that where there's very little warning, and it's the most, some of the most aggressive disease I've ever seen for sure. Um, well, in this patient, so the patient was started on a KIT inhibitor, stable for 1.5 years, and then this time did come with a bit of a warning sign with worsening cytopenias. Repeat marrow shows there's no mast cell aggregates, but 11% CD34 blasts. The KIT is undetectable by digital droplet PCR. The NGS shows the same three mutations at a little bit higher VAF and a new NRAS variant. So, Dr. Reiter, at this point, how would you approach this patient?
If I may add only one point to the diagnosis of the patient. I mean, this is a very typical case in which I would really like also to see better quantification of the mast cell infiltration. Just coming back to what Dipti said, about which disease is bigger. And I also very much like to have the KIT D816V allele burden in both the bone marrow and the peripheral blood. Because in blood, we usually have no mast cells in blood, or only very little fraction. So if the allele burden is low in blood, so it may mean that the AHN, at least regarding KIT, is not that much. But if the allele burden is 30 or 40% in blood of KIT D816V, it means that almost every cell in the peripheral blood is positive for KIT D816V. So I just wanted to add that when it comes down to the decision, with which drug I would start. And then now the continuation of the case. I mean, this has really been, one of the worst experiences for us, I think, in the past, that we see a patient with an excellent response. We do this routine monitoring, tryptase, KIT, everything is fine, the patient is fine. And then I very remember about 10 years ago where I was sitting. I remember the patient when I saw his blood count of 40,000 leukocytes. And I just thought, my God, what is going on here? Why has the patient 40,000 leukocytes? And it is just like Jela said, it was 4 weeks, while the patient has achieved whatever I thought is complete remission, and he developed AML within weeks. So, and that happened with midostaurin, and we see that now again. I think in Pathfinder it was about 15% of patients that they have progression of AHN. So they achieve complete remission on the mast cell compartment, but they have progression of AHN. And this is a very nice case in which we can clearly see that. And I would even add that I think, particularly in CMML, blasts may also be CD34 negative. So there may even be, a second blast population, which is even higher. And that is, for me, this typical progression of the AHN and rapid progression into whatever CMML2, or I would say that this is probably AML. And now the question is to me, I mean, of course, because when we now switch to chemotherapy, whatever, azacitidine or azacitidine in combination with venetoclax or even more, it definitely means that we have to stop avapritinib because of the platelets. Only if you're brave and the patient is brave, but usually, we would stop avapritinib with 50,000 platelets. And I have to say, I've now seen 2 patients, and this is also something I think really very important, which we have to collect the data, that this remission of the mast cells, I mean, mast cells are special cells, and this remission, and so they keep in remission even after stopping of avapritinib. And then I think you really have time to, in some of the patients, you have time to treat the AHN. Let me say, like in your case, I would not mind to stop avapritinib completely. I would monitor very closely KIT D816V, tryptase, the bone marrow with quantification of the mast cell infiltration, probably every 4, 6, or 8 weeks, But I would treat now, 100% the AHN with whatever, azacitidine or azacitidine plus venetoclax, although we all know that, these type of whatever secondary acute leukemias, probably the response is not really, I mean, the drugs are probably not as effective, or they are definitely not as effective, the combinations, as in de novo acute leukemia. And then, as Jela said, and when the patient then achieves a good remission or a reasonably good remission on my drug combination for CMML, I would also go for the rapid allogeneic transplant.
Okay, wonderful. Thank you. Thank you.
Can I just one point with that? The NRAS mutation doesn't bode well.
Yes.
In terms of timing, yeah.
Absolutely.
So Chella's absolutely right. For that first patient, sequential treatment to get both in a good place and transplant. But if they're in a good place, you need to hit that NRAS, which is very difficult to do, and get on top of that and transplant, in parallel fairly promptly, to get the best match possible. Sorry, Steph.
No, thank you. No, thank you for synthesizing that. That's wonderful. We'll go on to our last case, which is our longest case. And this is a 36-year-old man who's previously healthy, who presents with fever and fatigue, has a palpable spleen 8 centimeters below the costal margin, no other abnormalities on exam, has significant anemia, significant thrombocytopenia, 3% circulating CD34 positive blasts. A tryptase was not done on initial presentation, and normal liver enzymes and albumin. The bone marrow shows 20% CD34 blasts, 1 mast cell aggregate with spindle-shaped mast cells that express CD25 was also detected. This was also present on the diagnostic marrow, but not initially signed out on the bone marrow report when this was done in the community. And the molecular showed a KIT D816V mutation at a very high variant allele frequency of 40%, and cytogenetics showed translocation 821 in all 20 metaphases. So, question for Dr. Radia. And a very easy question. Well, it gets progressively harder in my opinion. But how does, in your experience, how does concurrent mastocytosis or concurrent KIT D816V affect your treatment approach to core binding factor AML?
This is bad news. Looking at the presentation of this patient, you really need to get on top of the AML. But it is a poor prognostic outcome from the start. So you need to maybe combine that with your KIT inhibitor to try and get on top of that particular disease for the AML. So if you're saying that's an easy answer, I think the outlook for this patient isn't particularly great, but AML combination therapy with a KIT inhibitor would be what I'd be going on from the outset. Transplant has to be at the top of that list if you try and get them into any sort of remission for a potential curative, but it depends on the timing and the response.
And
does that make sense?
Let me ask you then, because we're not going to use AVA with a patient who has AML. The platelets are going to go down below 50 with induction. So how would you incorporate, for example, midostaurin? Would you use it like the ratified trial with FLT3 positive AML where it's...
Yeah. So that was my next point, was obviously the more potent ones, you're absolutely right. You're going to walk down that terrible line that we were talking about, intracranial bleeds, and you don't want to do that. And I think that's where I would use midostaurin, even at a dose of 50, because that's what's been used with AML, and we know that will at least have some impact on the SM component. But it's really hard with these patients, because what you want to do is try and decrease the AML burden to try and decrease that to get the platelet counts up. So you are going to walk that fine tightrope, but you're absolutely right, Jason, not the more potent, Mido at 50. and then see, or you could sequence it. It's really challenging, isn't it? Because I don't think any of this has been done in a trial. It's a very poor, very small number of patients that don't do particularly well. I think both Andreas and Cella probably have more experience of these heading to transplant and how poorly they do. Or you could do the AML treatment with 50 of Mido and continue the Mido in the interim, supporting with your neutropenia and your platelet counts like you would do with AML. I think it's important to try and get on top of that SM component if you can.
I think the other question also is that, at least at Stanford, and I'm not sure how it is at other places, will I have an AML prognosis assay come back within 48 to 72 hours, and we can wait to start induction because we'll get NPM1 and FLT3 mutation status. But we do KIT D816V on our NGS, and that can take weeks to come back.
Yeah.
So you may not even know about their KIT status as you're starting to score chemo in. So how do you manage that issue? Or how do you do it at St. Guy's and Thomas?
So it takes time to get that PCR back, and I think this is where the bone marrow itself comes in useful, doesn't it? Because if you're seeing it morphologically, you're going to, well, I'm making the assumption that the majority are going to be KIT positive, and you don't have time to waste. And actually, with midostaurin, it is going to work whether you're wild type or KIT positive. So in terms of not wanting to lose time, I would be in favor of using that midostaurin. You wait to see what that result comes back. But you're absolutely right, the turnaround isn't that quick. But the challenge here is getting the most appropriate therapy in as quickly as possible in these patients. But like I say, I've only dealt with one patient like this. I know that Andreas and Cella probably have more experience to know which way to move forward.
Well, that actually, maybe I'll pose a more direct question, Cella, if you don't mind. If this was your patient, what specifically type of induction regimen would you use? We've touched on incorporating KIT inhibitors. Do you ever select induction regimens that incorporate cladribine or things like that? Or what kind of considerations do you have for induction?
So CBF AML, you are again very good patient to discuss. Is one way or another reason is the most common AML type with KIT mutation as well as SM associated SM. We don't know yet, but I am interested in CBF AML and KIT mutation, like Dipti says, is absolutely MRD positive. So you can say, well, PCR monitoring for MRD was successful. Yes, it was successful to detect the patients who will relapse, but it was so short. They detect the MRD became positive molecularly before doing anything, patients relapse. So even they concluded that, okay, you can monitor by MRD in this patient's CBF AML, but it may not allow you to intervene and reverse the course. So it is an evolving era. I am pretty sure MRD will be part of it. But short answer, after induction regimens, if it is translocation 821 and KIT positive AML, I will do allogeneic transplant. If it is inversion 16 and KIT mutated CBF AML, I will monitor them. I will not do transplantation.
Andreas, sorry, Stephanie, you're on mute. We're back.
Yeah. I think, I mean, can I start to say something?
Of course.
Sure, go on.
Yeah, I think AML is really probably a very spectacular field in association with KIT D816V. I mean, there was a paper from a pathologist cooperative group in the US, and they looked 100 of cases of myeloid neoplasms for KIT. To my surprise, they actually found KIT D816V. So in 50% of patients had acute leukemias, and 50% of patients had MPN and mastocytosis. And by far, not all the KIT D816V positive acute myeloid leukemias had CBF fusion genes. And we also published a couple of years ago a paper on AML with KIT D816V negative for CBF fusion genes and 40 patients from two cooperative groups in Germany. And the median survival of this AML cohort was 10 months. So in general, I think that KIT D816V is also doing really a bad job in AML, whether or not as in association with CBF fusion genes. And now I come to your case because, in your case, you say there is 40% allele burden, but in the peripheral blood are only 3% blasts. So if the allele burden is detected in blood and I only have 3% blasts, it would mean that other cells are positive for KIT D816V. So it would mean that there are monocytes, probably leukocytes. And that may tell me, and we have found such cases, that this is actually an SMAHN. An SMAHN with such a complicated mutation profile, which has acquired in due course the translocation 821. And then I think the approach is different from the approach when I believe that the blasts are positive for KIT D816V. And we have also found such cases. So when we got the material, so when we got CD34 positive blasts, in fact, we found more cases that the blasts are KIT D816V negative than that the blasts are KIT D816V positive. And I think this knowledge is also really very important in addition to whatever tryptase, mast cell infiltration. And what we have seen in some of these cases, so that you have very effective treatment of AML, the blasts are gone, you do a marrow after 4 weeks, and then you find 30% mast cell infiltration. Because with the remission of the blasts, the mast cells have again the space in the bone marrow to grow. And what I want to say, also in these cases, it's not so easy to make appropriate decisions at the beginning. You really have to look into the marrow. You have to do a trephine, or again after 4 weeks, you have to check, because you really have to find out, is this a de novo AML, which is KIT D816V positive, or is it an SMAHN progressing to secondary AML, and then having acquired whatever mutation you have found. And we have cases in which even the T8, 2, 3 cases, even which in version 16 or T821 is acquired in due course.
So, Steph, if you thought that was an easy one to start with,
Yeah.
it just goes to show how complicated the whole landscape is.
Yeah.
Even for those of us that actually look at these rare cases, it's a really tough decision to make up front.
Yeah, absolutely. And thank you for sharing all of your experience with how to manage these complicated patients. So we've talked about transplant and some of the considerations. If you are going to transplant with a patient, how do you incorporate KIT inhibitors? We've touched on this a little bit, but do you use them and hold them 5 half-lives before conditioning, and then post-transplant, at what point do you reintroduce them? Do you always reintroduce KIT inhibitors? Any considerations in that context?
Can I start?
Please.
So there's only Andreas, the German group transplantation study, had power to look at prior KIT inhibitor use, the effect of it in allogeneic transplantation outcomes, and they reported that it is positive if they received KIT inhibitors. It makes common sense, and there is one study supporting that, so I think it makes sense to use an effective KIT inhibitor before transplantation. When to stop, maybe like you suggested, 3, 4 times their half time before the conditioning regimen. Post-transplantation use avapritinib or midostaurin. Obviously, there are patients that it used in progression and had good results, but case reports these are. I also use in progressive patients. The Chinese group has the most experience, and they published. They look at MRD. They use avapritinib not in SM, but again CBF AML. They use KIT inhibitor, KIT mutated CBF AML. They looked at it, and if MRD becomes positive, they use it to rescue these patients before relapse. They had 20 patients, and in these 20 patients, 17 had a good outcome, 3 progressed to leukemia again. Obviously, thrombocytopenia will be a huge problem for avapritinib use, but we will see post-transplantation avapritinib one way or another, more and more. That's my assumption. And how is it, when to do it in progression, or when to detect the MRD with the donor lymphocyte infusion or alone? We need some time to observe and understand better.
So if I can just point out, when we had the EBMT good practice guidance, the jury's out. We don't have enough data. I think we chose 2 weeks before a transplant. The best response for SM, we know going in with the lowest disease burden is best. And we chose 2 weeks because it was fitted with the half-life, so you didn't want to leave the patients too long. I think we had a big discussion about what do you do post-allo, what would be and you're right, those patients who relapse, they've got a high tryptase, you look at their bone marrows. And I think that's something that we've always discussed, haven't we, Andreas, that when the post-transplant needs to be an aspirate refined tryptase, getting the SM component to look at that MRD with the c-KIT VAF. Because, avapritinib or midostaurin and using all the immunosuppressants, there are going to be issues with when you can use it, the thrombocytopenia, the recovery, and there's going to be interactions with those medications. So I can say for the few transplant patients we've had, if they've been in an ISM or they've had a very low rise in their tryptase, but their bone marrows are not showing a significant mast cell burden, I've not pushed to go in and use a TKI. I've kind of assumed they're in an MRD from their AHN, which is what the reason for the transplant was, and the SM is being monitored, provided that you are actually keeping a 3-monthly eye on it, because things can change to then introduce it. I don't think we have, or they've got high molecular risk signatures. I don't think we have enough data to say when. I know, Andreas, you published those cases or you presented them where you've used it afterwards, and I don't know whether that context was that they'd relapsed anyway.
Well, I think I would make this decision also upon the remission status prior to transplant and the risk of relapse after transplant. So I think it is a big difference whether I go for transplant when the patient is really in complete remission, so no mast cell infiltration, no KIT, no tryptase, or whether the patient was transplanted, let me say, with a SM CMML, without really a very good, only blood counts are good, but everything else is elevated, and then I do the transplant, because these patients are really at very high risk of relapse, and then I may consider the earlier use of the KIT inhibitor, and particularly of avapritinib, also after transplant.
I think we highlighted 3 kind of cohorts. Those who, you're absolutely right, those who didn't achieve a very good response or a CR moving into transplant. Potentially the mast cell leukemia patients may need an earlier reintroduction to a TKI, and then watch very carefully to decide when you go in, because you might need to. And we don't know the dynamics post-transplant of when patients may get a relapse.
Yeah, I think particularly, I mean, the problem is really that also in our data still the outcome of mast cell leukemia after allogeneic stem cell transplantation was still very poor.
Mm.
So I think at least you also have probably to consider different strategy for every patient with mast cell leukemia, and particularly for those with mast cell leukemia and AHN, because I mean this is really like yeah, worst scenario acute leukemia.
Thanks, everybody. This is bringing us just to the hour. And so I want to just finish our last questions here. And then, so I'd ask an even harder question that maybe it's easier because there's no right answer. But if this were a different favorable risk AML subtype per ELN, would that change any of your approach here at all? So if it wasn't core binding factor, but another favorable risk AML, but they have concurrent KIT mutation or concurrent mastocytosis, do you favor going to transplant in the frontline setting?
I
So I guess
think
Chell answered that, didn't he, with the inversion 16 and the 821. But I still ask that question up front for an only curative option if they've
Mhm.
got a good match. And I think this comes back to the transplant variables as well.
Right, of
You know,
course.
they've got to have a good donor, they've got to have a good match, their comorbidities, the kind of nick factor for that patient, and whether they would be a good transplant candidate themselves. I think it's a question you ask up front when you see these patients, and then you may tailor whether that's upfront or whether you go for treatment to get them into remission and then see.
Okay, wonderful. And
I
then,
I just would like to add one point. I mean, before I've mentioned, that it could be secondary AML progressing from SMAHN. I mentioned de novo AML, KIT D816V positive. But the third scenario is that patients may have two independent diseases. They may really have indolent systemic mastocytosis and AML, and we also have found such cases. And for me, as I said, this is extremely important because it's so a different treatment for me. I would of course treat AML like I would treat de novo AML, but it's really all about, can I include a KIT inhibitor already, like for FLT3 positive AML, within the induction, very, very closely, or should I wait until all the, induction consolidation is finished and then only to add a drug like avapritinib, which I may not be able to use during chemotherapy because it's just too toxic for the platelets. And I think the knowledge really, what is mastocytosis? Is it independent disease? It is in,
mhm,
and I think you need all this information. In addition, what you say about the AML subtype to get the best decision for the patient. And then it also what Dipti said, I mean, the availability of a good donor and the comorbidity of the patient is also very, very important. I mean, I have seen too many patients with this MCL-AHN progressing to AML. And I mean, many of these patients are just not eligible for allogeneic stem cell transplantation.
yeah, that's right. Well, we are at just over the hour. Jason, are there any questions that we haven't already covered that you'd like to share at this time?
Actually, there are no current questions in the chat, and I think the discussion has been wonderful. So I'll give it back to you, Stephanie.
Okay, well, thank you everybody for joining. I'd like to thank our expert panel for joining and creating such a wonderful and educational discussion. I know I definitely have a lot to take away. Of course, to thank my co-host, Dr. Gottlieb. I've put the AIM website here for people's reference, and if anyone has any questions, I'm very happy to take them, and that's my email below. So thank you all very much, and this concludes our first webinar. not without one technical glitch, but I guess that's the way these inaugural things go. So thank
It's
you all
amazing.
again for all your time and sharing your expertise with us. And we look forward to seeing everybody at the next webinar.
Thank you for
Thank
the
you,
invitation.
Stephanie.
Thank you,
Thanks,
everybody.
folks.
Yes, and
Thank you for the
Yes.
invitation. Goodbye.
thank you. And
Goodbye.
this will be posted on the website. Take care, everybody. Thank you.
Bye.
Bye.
Bye-bye. Bye-bye.